Well, hello, everyone. I have the enviable task of interrupting a lot of nice conversations going on all around the room. So apologies for that, but Ariel made it very clear that I needed to get back on track here so we can get this back on time. So I'm Dr. John Ward. I'm the director of the Coalition for Global Hepatitis Elimination at the Task Force for Global Health, which is a nonprofit organization started by former CDC directors about 40 years ago that works on a variety of disease elimination programs. And I moved over from my previous position as director of the Division of Viral Hepatitis at CDC to start a global hepatitis elimination program at the task force. I continue to work with my colleagues at CDC as well as the National Cancer Institute, which I also have an appointment with. We can talk a lot about what's going on around the world, and I'm happy to do that at any time, but I thought I would really see what I could bring together to be very relevant to the conversation we're having today about what are some ways that we can advance toward hepatitis C elimination in Texas by various policy options. And so I'll be looking a little bit about hepatitis C transmission and disease, prevention, care, and treatment, the benefits, some strategies to expand access. Hope I can make a very good case for simplification for hepatitis C care and treatment, as well as prevention. It was very exciting to hear from Hashem that you really want to bring together a coalition. I mean, that's what we're all about at our coalition, global coalition, as we really seek to foster coalitions at the national and subnational level, and look forward to working with all of you to see what we can do in our part to help you bring that about. We really have a remarkable opportunity that doesn't come along your way very often in medicine, where you have this major breakthrough in medical science that opens up new possibilities to improve health. And we absolutely have that for hepatitis C virus. As probably most of you know, 3 of our colleagues were awarded the Nobel Prize in Medicine for their scientific contributions leading to the discovery of hepatitis C, which was published by Michael Houghton and his colleagues in 1989. It was for the disease that used to be called non-A, non-B hepatitis. We now had an etiologic agent that led to the development of reliable tests and led to the discovery and of the various replicative pathways that made identifying targets for therapies possible, leading to the cures that we have today. So, as I see it, it's our opportunity to turn a Nobel Prize into a noble cause. How do we really seize on this major scientific breakthrough that led to the first cure of a chronic viral infection in the history of medicine, hepatitis C virus? Now, how do we do the right thing and make that science, translate that science into good health practices? Where we are today about preventing transmission is of this bloodborne virus is particularly for the United States is for people who inject drugs. Now, around the world, the most common mode of transmission continues to be unsafe health care, blood transfusions that aren't reliably screened, and the like. Now, that still occurs occasionally in the United States, but the major driver is ACV transmission among people who inject drugs because they're using unsterilized, non-sterile equipment, and they're sharing that among themselves. And hepatitis C virus is very transmissible, much more so than HIV. And as a result, you get very high incidence rates, as you can see here, right after the initiation of drug injection behaviors, with an overall prevalence among drug users globally of about 50%. So that's your highest risk population. Now, what we have before us, as I mentioned, we have the opportunity to test and cure. We have, with 1 or several pills a day, 2 to 3 months of treatment, 90% or more are cured of hepatitis C. These drugs have shown themselves to have an excellent safety profile. And what was once thought to needed therapy to be overseen by multiple clinic visits and the like experience has shown that that's not the case. There was a landmark a study called the MINMON study last year that showed you could give the whole treatment regimen up front to the patient, not see them again until you went into the completion of therapy. This was in multiple countries, and you got around a 90% cure. So on comparability to looking at them more often, which was more complicated. So you have a very highly effective, safe, and that can be applied in a variety of simplified algorithms. Now, one of the issues these drugs first came out, as most of you know, they were very expensive, over $90,000 per cure. And so as a result, a lot of Medicaid programs put up very onerous restrictions, which we're going to get to in a moment. But those costs have declined dramatically in the United States, which I'll touch on, and also around the world. So from about 2015, where a drug was costing about as I mentioned, over $90,000 per cure, you can now get equally effective treatments in other countries for less than $200. And it's really a remarkable opportunity globally. The WHO, World Health Organization, in part because of the availability of these new curative treatments, has targeted hepatitis C and hepatitis B as elimination of a public health threat, defined as a 90% reduction in transmission, 65% reduction in mortality. Those goals were first put out in 2016. And they approved by the World Health Assembly, and then re-voted on and approved just this past May. So we have universal approval that these goals for hepatitis elimination should be achieved. How big of a problem is this globally? We have about 58 million people living with hepatitis C, causes about 300,000 deaths per year, and about 1.5 million new infections a year. This is the problem largest in certain parts of Africa, particularly Egypt, had the highest prevalence. Certain parts of southern Asia, such as Pakistan and Bangladesh, certain parts of India, Eastern Europe also have high rates also. Here in the United States, we estimate that there are about 2.4 million people living with hepatitis C. As was mentioned earlier, we have a real baby boomer phenomenon here that was particularly evident in earlier years, where you really had this faith. If you looked at the epi curve for hepatitis C, you had this faithful curve moving through time, which really led me to believe, we really should be targeting them for testing, which led to our birth cohort recommendation for HCV testing that we put out in 2012, as well as continuing to target persons that have risk factors for transmission, such as persons who inject drugs. And we had a lot of merit because before the virus was discovered, blood was not being screened. Universal precautions that gradually began to be put in place through the 90s, in part because of the AIDS epidemic, were not in place. And there were a lot of other risks in society over and above the major risk of people who inject drugs. And I also thought it was a great way of destigmatizing screening and treatment. But even today, about only 60% of people with hepatitis C report their awareness of infection on national surveys, such as in Haynes. When you look at in Texas, when you compare the prevalence rates there on the left, you see that it's fairly similar to the country as a large, with maybe a slightly larger prevalence among the baby boomer cohort, equivalent among younger people. This particular analysis did not have any information about Hispanics, which is a racial and ethnic population we're very concerned about here in Texas, as was described earlier. This just shows you the mortality rate. The red stars show you again where the mortality is highest, is in this baby boomer group. And of the racial and ethnic disparities there on the left for American Indian and Alaskan Natives, and for blacks. Again, some of the demographic trends that we've already touched on here. As I mentioned, our first move toward a general population screen was targeting these baby boomers because they were the majority of people living with hepatitis C. The studies we did using APRI and FIB4, the serologic algorithms that were discussed previously, we showed that half of those had moderate to severe liver disease already, and many of them were unaware of their infection, so we had a really strong case for making this a national recommendation, and it was adopted by the U.S. Preventive Services Task Force. And it takes a little time, to get these policies routinized, and let alone all the challenges that we've already been hearing about. But we did begin to see some increases in uptake in hepatitis C testing, looking at different data repositories of medical records between 140% to 375% increases in testing. So policy change does translate into practice change, even when you have a very modest budget for health promotion and clinical training and the like. We did, over time, identify implementation strategies that were very important. Electronic prompts, as I've already mentioned. Reflex testing, whereby the HCV antibody positive specimen in a laboratory was automatically tested for HCV RNA without the physician having to order that, or the patient return for a second specimen. Importance of clinical education, care management, limiting cost, some of the other strategies that we've already touched on. So we really have a pretty robust toolkit, actually, of what works for hepatitis C. But now we have this new problem over the last decade now of new transmission risk and the growth of the size of this risk population of people who inject drugs, driven in large part by the opioid epidemic and the people who move from oral to injection, of those medications. And we've had almost like a threefold increase in incidence because of that, as you can see there in the line graphs on the right. Now, Hep C treatment does work for people who inject drugs. They have similar, comparable treatment outcomes. Adherence sometimes gets raised as a reason not to treat them, but adherence does not have to be rigorous to get high cure rates, including for people who inject drugs. Then people worry about reinfection, but reinfection is about 4 per 8 per 100 person year, so you have about a 4 to 8% reinfection rate, per year. That's not exorbitantly high, and those studies do not include other ways to limit their exposure, such as making sure they have sterile equipment, et cetera. So there's a lot of good reasons to prevent HCV, as well as to make sure those individuals do not progress to cirrhosis and liver cancer. And there's a lot of good, cost-effectiveness data to back that up. So this is where that curve has changed. We used to have this faithful birth cohort curve moving through time. That's now been joined by this second curve of new cases of hepatitis C among young persons, as you can see here. And now we have a bimodal curve. So let's just talk about, now that we have that sort of epi as context, where are we now in our strategies? As we've learned more in treating hepatitis C, the recommendations and the epidemiology has changed. First, we've moved from a birth cohort recommendation alone to a recommendation to treat all adults, which came out in 2020. That CDC recommendation was joined by the U.S. Preventive Services Task Force recommendation, which should make that a no copay preventive service for people going through primary care. It'll be interesting to hear how well that actually plays out, but it does at least give you a policy and perhaps some financial support for expanding testing so that all adults have access to this to this screening. The question then is the implementation of that policy. Treatment recommendations have also been simplified, as I've already alluded to, so that many of the requirements for staging, for finding and having patients return to the care setting over the course of their treatment has moved away. And in fact, when you go around the world, it's there's very highly successful programs in many other countries, very much simplify staging ahead of time, with the greatest concern obviously missing cases of cirrhosis that need more attention, or the patients that perhaps are on HIV therapy, and then you have to worry about some drug-drug interactions. But for the most part, this is the regimens can be very simplified, and I think it's a real credit to AASLD and that they've really sought to do that and really been a champion of moving HCV care from the specialist to the primary care setting. There are some great examples of highly effective programs. As was already mentioned, the veterans, the VA is definitely one of those. Because of this birth cohort phenomenon, Vietnam veterans had a very high rate of hepatitis C. And so certain veteran organizations were very, very concerned about hepatitis C, and that translated into congressional attention and congressional action and great funding for a program. The VA made very good use of that with developing highly structured programs, which they called HITS, Hepatitis C Intervention Treatment Services, I believe, where they really made sure that they were getting good feedback about what was working, so they could continual quality improvement. They had a great data system, great outreach, and great financial support and negotiation for affordable treatments for the system. And as you can see, they had large reductions in those that were awaiting treatment. And they feel like they've treated they've screened over 85%, and feel like they've treated over 85% of their hepatitis C population. So there's a lot. That's one example. Another example is the Cherokee Nation. Although we should look at some of the programs close to Texas, and Cherokee Nation in eastern Oklahoma came to CDC in collaboration with the University of Oklahoma Medical System, really wanting to put together a program. American Indians have high mortality rates from hepatitis C, and so they developed this program. I like this quote from the chief because I think it emphasizes the key importance of political commitment and to a program. There's an old adage in disease elimination that political commitment is as important as technical proficiency in the success of a disease elimination program. And I think that's what we're really talking about here when we think about policy change. But here on the left, you can see some of their strategies for implementation. Universal screening, which started even before the recommendation came out. Patient navigations, having that testing available throughout their system, making this available. I think pharmacists were treating 25 to 30% of the patients, and continue to do so. And now that they've really had this become a routine part of their health system, have now moved over and tried to do more outreach for people who inject drugs and begin to bring that together with harm reduction, as I'll speak of in a moment. You can see the care cascade here. They're particularly, concerned about this drop-off between the linkage to care and the starting on treatment. And in talking to Dr. Jorge Mira, who some of you know, who was the director of this program, felt like one, critical barrier that has yet to be overcome is that they still have to get the medications from another source. And so you still have this gap between seeing the patient and that patient getting prescriptions, and that's just, and he feels like that would be another sort of practice change that would improve this care cascade. There have been a number of sort of local programs that have started to move toward hepatitis elimination as the cost of treatments have declined. A study several years ago by Dr. Jack Chadwell in Harvard estimated that any cure less than $40,000, given the cost of liver transplant and the other costs that were already mentioned earlier, makes Hep C cure cost saving in the U.S. health system. So we're clearly in cost saving territory as a nation. The other novel program that just started right before the pandemic is in Louisiana, where they champion what's called the subscription model, or the so-called Netflix model for hepatitis C treatment, which was really pioneered in Australia, whereby you give the pharmaceutical company, you negotiate one price, and you pay that price for unlimited access to to treatment. So the more you treat, the cheaper per patient it becomes. And it's also a very powerful incentive to test, because you want to test and find those people so you can drive down the cost overall of your program. So they implemented that in Louisiana, along with the other features that you can see there regarding patient and provider education, and they put this in place in their correctional system and for their Medicaid populations. And you can see the line graph of those starting on treatment for hepatitis C. Even during, there were some, there's been some dips, and they have incomplete data in the most recent year. But they saw, the subscription model was, definitely increased the number of people that were being treated in Louisiana among populations that were very marginalized to receive care to begin with. So it's, the program is ongoing. They feel like it's on, the right track. And there's a lot of lessons to be learned from that, as I'll allude to in a moment, at the national level. The other part of this, they thought they also had some waivers for the capitation rate, so that the cost of treatment and care for hepatitis C was no longer applying against your budget for a Medicaid program. So that was also considered to be another policy incentive that was put in place here. So if Louisiana can do this, certainly Texas can do it. I was been talking to Dr. Risha Irvin from Johns Hopkins, who's helping Louisiana evaluate this program. They feel like this is demonstrating high acceptance rate for testing and treatment in a correctional setting. They feel like for the correctional setting, screening people as they come into that setting and as they leave is really, really, really important. And there was high acceptance among prisoners with this opt-out strategy. You can give a full treatment course on exit. They would like better linkage to a community setting to complete that treatment or to document cure. So they feel like that's another example of a work in progress. And then they would like to move just from long-term incarceration facilities to jails and looking at people on probation and parole, et cetera, and really making an all-judicial system program. I've already touched on, some of these strategies, but it doesn't hurt to look at them again, just to emphasize that we have a very robust toolkit, and there are challenges before us as to how to implement those. Now that I'm working at the global level, I have a better appreciation of what's going on in other countries. I've already mentioned treatment cost that used to be a huge barrier is rapidly becoming not one. Not universally yet, but 2/3 of all people living with Hep C now live in a country where the drugs are very affordable. So the current challenge is not so much the cost of treatment, it's the testing. How do you get people to test and how to find those people? So you have to have a policy, the training, the data to show how well you're doing. And then the cost of those diagnostics in many countries now are more expensive than the therapy. The cost of an HCV PCR in the Democratic Republic of Congo is like $180. It's probably more expensive there than here, just because there's only one or two laboratories that have that kind of equipment. Now, I'm interested to see how the response to COVID-19, with these billions of dollars going out to improve virologic testing for COVID, could be applied now to hepatitis C. But those are some of the barriers that we have to continue to be vigilant on. And what we want to look at, for discussion in the afternoon is, how do we, get more people treated? This was a recent analysis from CDC looking at claims data for 2019 and 2020 for 2 million people, just looking to see what percent were prescribed an HCV medication within a year of a documented RNA positive test indicative of virologic positivity, and showing that a minority of patients were being treated, within that period of time. And in the states that had Medicaid restrictions, that minority was even greater. So we need to explore, what are the reasons for that. But this is a good surveillance data to help us begin that kind of questioning. One of the areas, though, is Medicaid treatment access restrictions. And Adrian Simmons and Sarah from the National Viral Hepatitis Roundtable, and they, along with their colleagues at Harvard, have been doing a great job of monitoring these restrictions that, as I mentioned, were put in place earlier on because of the concern about the cost of HCV medication. So they were restrictions based on your stage of liver disease, fibrosis, whether you were a specialist or not, whether you were had some reason that they thought threatened your adherence, like alcohol or substance abuse, known as sobriety restrictions. So we're going thought it'd be good to get a little bit of an update on that. So here, there are 38 states have no prescriber restrictions. So it looks like Texas is one of those. All the restrictions have been removed based on liver damage, so you don't really have to wait till you have cirrhosis to finally get treated for hepatitis C. So those are some of the positive aspects of changes in policies over time. Sobriety restrictions, again, vary between just downright denial, which are in the dark red, versus the lighter red, which include Texas, where the provider must address some type of counseling or education to a person prior to their treatment, which doesn't seem to be that onerous, but it's just one additional step that could result in someone not getting the treatment that they need. And we already have good data that substance abuse does not impact treatment outcomes. Prior authorization to prescribe treatment is a major barrier that I hear from prescribers in multiple states, where you have to get approval before that prescription can be filled. And just really with all the busy and all the other competing priorities that we heard about this morning, it's just one more hassle that you're making primary care come through. For me, it's, Hep C treatment, it appears, is not complex. It's the system that you're having to work in to deliver that treatment. And I think this is an example of how you're making that system actually more complex and unnecessarily so. That could be avoided. There are many other restrictions. 27 states require documentation of genotype. We'll get to that in a minute. 15 states require documentation of chronic infections. 20 states require the lab to be collected within a certain time frame. 9 states impose barriers to replacing lost and stolen meds. So like if you lose it, too bad. 23 states impose adherence to adherence requirements. And there's restrictions for retreatment, including Texas, that you have to go through extra steps if that patient comes back, either because they failed treatment or they have been reinfected. So just as summarizes the Medicaid criteria for treatment in Texas, permissive, no fibrosis restrictions. You can be a primary care provider to prescribe, which is good. Managed care organizations cannot apply extra restrictions over fee-for-service within Medicaid. The restrictions, prior authorization is required for all treatment, which is, I think, a major barrier. The other one that I really found, frankly, surprising is the continued documentation of genotype. We have pan-genotypic regimens. This is not recommended by any liver organizations, AASLD, et cetera. So that increases cost and is another barrier to care. There are limitations about laboratory testing and when it occurred, and the other ones listed there. So there's a pretty onerous list of restrictions for a treatment that's only 2 to 3 months. Studies show you can give all of it right up front, 90% cure, very few drug-drug interactions, and very, very safe. And of course, I think about other countries, and this just shows you an example. We're doing these national hepatitis elimination profiles that's available up on our website at globalhep.org, just to show you that many other countries have greatly simplified, their treatment. And these are just the ones I sort of just pulled a sample from Europe, Asia, the Americas, to show you that other countries are proceeding on with simplifying hepatitis C care, and it's certainly time for us to do that completely for our patients here in Texas and the U.S. But we can't forget, the sort of the community-based prevention that needs to happen for us to cut off that channel of new infections and protect people who are at risk. In our case, people who inject drugs. And you have to do that not only with test and treat, but you have to make available sterile injection equipment through what's called syringe service programs. It's recommended that every person who injects drugs should have about access to about 200 exchanges per year to really be protective, optimally up as many as 300. And here in the U.S., it's only about 30 per people who inject drugs because of the relative paucity of these syringe service programs around the country. And drug treatment programs are also under resources, and so there's a long waiting list oftentimes for people to get in drug treatment. And then for us, that testing for hepatitis C in those settings is not done reliably, even though it's the highest risk population in the country. So there's a lot of service strengthening that is needed for harm reduction and preventing transmission of hepatitis C. We did this study a number of years ago now, and we did an overlay. The red dots show where new cases of hepatitis C were being reported in the country. The black triangles were showing where was there a syringe exchange program, and just show you the non-alignment of the risk populations with where these prevention services were being applied. And you have to admit that we need more black triangles all over the country. But this illustrated the point very, very well. And then we estimated that we would need another 2,200 programs to have these conveniently available to match this growing population of people at risk for hepatitis C. And I gave you some other data there to show you the lack of delivery of hepatitis C testing in primary care and in these drug treatment settings I've already mentioned. The other population that we're concerned about are pregnant women. There's about a 6 to 12% risk of transmission from mother to child, so not as large as for hepatitis B or even for HIV, but still one that we need to be reflective of. Kentucky, which has rivals West Virginia and having the highest incidence of hepatitis C in the country, have very high rates of hepatitis C among pregnant women. They're still the only state that requires pregnant women to be tested for hepatitis C, so that's a credit to their public health system. And then overall, about 1 out of every 300 births in the U.S. is to a woman who is infected with hepatitis C. translating to about 1,700 children being infected per year in the country. So that's so we just started a registry to get more information about those in collaboration with CDC. So and also this is an opportunity to test and treat that mother after delivery now, as there's not a recommendation to treat Hep C during pregnancy. So I believe now is the time to eliminate hepatitis C. I've already sort of hopefully made the case for that. So that sort of gives me an opportunity to talk about our newest, most highly visible, credible champion in the United States for hepatitis C elimination in my whole experience of working on Hep C, and that's Francis Collins. He's the former director of NIH. He's now President Biden's science advisor. And he called me up in March and says he wanted to put hepatitis C elimination as part of the cancer moonshot for the U.S. And he thought it would be a quick win, to show why you need to have a cancer moonshot. And he was a big believer in that. I think our colleagues, Doug Lowy and others in NCI, was a real help bring Francis up to speed about that. And he stayed true to that vision. And he had a meeting about several weeks ago in August. I think Adrian, perhaps some of you others, listened in on that or were there in the room with Adrian and I to show to propose this national program and to find a way of making treatment more affordable, expand testing, and expand access and use of those tests. And then to have that programmatic support that we've been touching on already as far as expansion of drug treatments or in-service programs, clinical training, health promotion in the community, hepatitis surveillance, and other strategic information that we've been touching on. And that's very much what we are all about on our coalition on the right. How do you put together all these key components to make an effective program? So it was really great to hear Francis championing that at the White House level. With Jack Chatwall, we put together what are the benefits of this new program. If we could fully implement it, the little box up there on the top right, just versus the status quo. If we did a better job of full expansion, had a fully comprehensive program, we could avert an additional 70,000 deaths by the end of this decade, and over 340,000 deaths by 2050. By incidence, by including that those prevention services for people who inject drugs, we can avert almost 300,000 new infections by 2030 and 1.2 million new infections by 2050. And we would save about $50 billion in healthcare cost, and about of that $54 billion, say $50 billion of that would come and be saved by the Medicare and Medicaid program. So we thought we made a strong economic argument for the national program. Francis and his colleagues are now seeking to bundle that together to see how that can be put into the president's budget for FY24. So we'll see how that goes. So my take-home points: HCV is a major health problem that can be prevented. I would have to say, when we look at the causes of liver cancer, it's great to see that 70% of liver cancer can be prevented. I would submit that of all those causes, Hep C treatment and cure is the easiest, the lowest hanging fruit of what we're talking about. It's much more easier to cure Hep C than to, for weight loss, alcohol cessation, and the like. So let's get this done. Prevention programs can prevent 90% of new infections. We got to scale up that at the community level. We have a robust toolkit to make testing and treatment available. We need to begin to apply it and remove barriers, some of which I touched on with Medicaid restrictions as an example. And if we do all this right, we can achieve elimination and have benefits in lives saved and costs saved in our health system, as I will emphasize there. So thank you very much.
I'll just say it here. Wasn't this great or not? I mean, this is amazing. We're waiting for some action. Here's some action. Any questions or comments? While you still have him, he's coming from Atlanta just to do this. Please, Dr. Pond.
I was just curious on what's the current cost for treatment in the U.S. now? You mentioned it used to be $90,000, but it's like $200 in developed countries.
It's very hard. Maybe Adrian may have some. Sort of the recognized cost is about $26,000 for the AbbVie drug. It's often thought that the negotiations between health systems and pharmaceutical companies and pharmaceutical managers, you get less costly drugs. The VA, was my understanding, was more in the high teens.
Yep.
Now, in that Louisiana program where they had that subscription model, they were estimating that based on the number of patients treated per year, which went down during COVID, that they were varying between $3,500 to $7,000 per patient treated. So, Adrian?
Yeah. Sorry, why is it 20 times more in the U.S.?
That you can say that about many parts of our health system. Rents are higher here. There's a lot of other things that are higher here. So I think, it doesn't necessarily bother me that it's $5,000 versus, $150 in Pakistan. But I think it's for me, it's down to a level where it's fully, it's highly cost saving. You're saving lives. And you look at other things that our system is paying for, this is a very good buy for the patient and the health system.
The only thing that I would add to that is that the $26,000 number is the list price that you would most commonly see, so that's the sticker price of the drug. But most health systems that are participating in the 340B program are purchasing the drug at about $10,000 to $15,000 per treatment course. And then, as Dr. Ward mentioned, that price comes down even further if you have something like a subscription model in place. So the cost has come down dramatically since these drugs came to market in 2014. Everyone referred to it as the $1,000 pill a day, and it was nearly $100,000 per treatment course. So now that we're in the $10,000 to $15,000 range for most health systems, we're certainly in the cost savings arena.
Absolutely.
Fantastic. Other comments? Well, John, you're hanging around, aren't you, for the next hour or so, so don't leave. To stay on time, our next speaker, and the one before the last, is Dr. Salil Deshpande. He is the Chief Medical Officer of United Healthcare Community Plan. He trained at Baylor College of Medicine, followed it by a business degree from Wharton, and a dear friend. So thank you for coming here. Look forward to your talk.
Thanks to Dr. El-Serag and the entire tech team for including me here today. As he mentioned, I am your friendly neighborhood representative from the dark side this afternoon. But in all seriousness, actually have been really profoundly impressed by the fact that, just as an example, that oncologists, that hepatologists recognize the plight of the uninsured, the underinsured, and the challenges that that their social issues bring, and how relevant they are in actually making a dent in what it is that we're trying to do. Over the next 20 minutes or so, I'm going to just share a little bit of insight and thoughts from a healthcare payer's point of view around the continuing opportunities with liver cancer, and in particular, a potential roadmap and some avenues for change as we go forward. So I'm Salil Deshpande. I'm an internal medicine physician. I've been with United Healthcare for about 15 years now. I'm the CMO for our Medicaid health plan, where I've been for almost the past 10 years. We have the privilege of serving a variety of people across the state of Texas, ranging from pregnant moms and their newborns to dually eligible Medicare and Medicaid members, to both children and adults with special health care needs, chronic medical conditions, and in many cases, concurrent coexisting behavioral health challenges that they're facing. And so all of which is to say, we're certainly no stranger to the challenges of liver disease and even to liver cancer among our population that we're helping. So let's move along here. Today, in my brief time with you, I want to really focus on three different things. First, I want to bring to you the payer's perspective on liver cancer. Why is this issue important? What are some of the statistics, risk factors, and economic considerations that make us pay attention to liver cancer? And I'm not necessarily going to be telling you something that you haven't already heard over the course of the day and this morning, but I really want to sort of highlight what it is that jumps out to the payer community. From a payer's perspective, what can healthcare providers be doing to prevent and to screen for liver cancer? Again, from our perspective, what are some of the issues and current opportunities in treatment and clinical practice that we are noticing in the community? What is the role of a managed care organization's disease management program? And what are the opportunities around our relationships with our network providers, again, when it comes to liver cancer? So first, we'll talk about these things from a payer's point of view. And then, and especially since I'm coming to this conversation from the angle of a Medicaid payer, we'll speak about a few levers that the state Medicaid agency, and in this case, the Texas Health and Human Services Commission, some of the levers that they can pull to impact and address opportunities as well around liver cancer. And related to these state regulatory levers, I'm going to just briefly summarize Texas Medicaid's upcoming policy changes that some of you may already be aware of, but I just want to point those out as well, specifically pertaining to hepatitis C virus treatment, and which, of course, as we've learned just recently from Dr. Ward, is really one of the most critical levers to pull to mitigate liver cancer. And then third, I want to look at a framework for potential policy change and specific policy recommendations. And for that, I'm going to draw from a national framework, a collaborative of state Medicaid agencies that had been pulled together specifically to focus on hepatitis C. Their findings and their activities are themselves relevant to what we're talking about today, but I think that structure and that framework can also be more broadly adapted to liver cancer as well. All right, so we know that hepatocellular cancer is the most rapidly increasing cancer in the United States. We have talked about the fact that in Texas, the incidence is just amazingly high, about the highest of all of the states in the country. We've got about 3,700 new cases annually here in Texas. 50 or over 50% are due to viral Hep B and C. Eliminating hepatocellular cancer really requires increased access to screening, diagnosis, and early treatment, whether it be for the viral conditions or otherwise. What are some of the economic factors that make us pay attention to liver cancer? So the median direct cost of a patient with liver cancer in the United States is just under $200,000. The estimated cost to the U.S. healthcare system for treating about 40,000 cases a year is, and this was just already more than 5 years ago, was over $4 billion. So again, I said that's the cost of the U.S. healthcare system. This doesn't even include all of the indirect costs that might be related to the patient's to the patient's inability to work, or certainly time taken off by caregivers and so on. Again, much of our data comes from the VA, the largest provider of patients with hepatocellular cancer. And interestingly, what we've learned is that the cost for somebody with cancer is twice as much as that for someone who has cirrhosis, which of course in and of itself is significant. And then a transplant for those people in whom it may be appropriate and indicated can add substantially to that cost, up to $400,000 as well. All right, so what do payers think about the opportunity around prevention of liver cancer? So again, we've talked about how over 50% of all cases are related to Hep B and C, so there's clearly the need to focus on prevention, identification, treatment of those viral infections. We've talked about alcohol. We've talked about NAFLD. NAFLD's prevalence is, perhaps a quarter, perhaps even higher in the state of Texas. It's interesting and maybe even a little scary that NAFLD can lead to cancer even in the absence of cirrhosis. Perhaps that's not the largest majority of the time, but still an issue. Doctors sometimes think of NAFLD as the liver presentation of metabolic syndrome, and again, we've alluded to the fact that in Texas, we're an obese state. We've got a significant proportion of our citizens who are diabetics. So all of this metabolic syndrome closely linked to obesity, inactivity, likely an opportunity to focus on that. Certainly starting right from childhood and into adulthood, the opportunity to increase weight loss, improve obesity, and so forth. Okay, let's move on and talk a little bit about what payers think around guideline recommended screening for liver cancer in particular. Obviously, it's cost effective to identify and treat somebody earlier than later. Certainly there's a higher probability of someone benefiting from curative therapy and hopefully a potentially longer survival. The reality, again, as we've acknowledged throughout the day, that many patients who have undiagnosed hepatitis C, as well as those people who have liver disease or even cirrhosis, these are patients who are being followed, well, hopefully being followed by primary care providers. So certainly a tremendous opportunity to focus on primary care in that opportunity to screen. There have been a couple of studies that have shown some things that I think are quite disappointing. First of all, 40%, up to 40% of PCPs are not familiar with liver cancer screening guidelines. So that's disappointing right there. Up to 30% of PCPs don't think it's in their wheelhouse to be worried about this. That's even more concerning. And certainly that raises, these collectively raise very specific opportunities here. The takeaway is that there is an opportunity, and perhaps as early as at the point of medical education, to really educate providers about correct screening modalities, potentially how to take advantage of electronic health records, to have reminders to do so, to employ outreach coordinators if that's available to them in their practices, what have you. All right. With respect to treatment, what are some of the concerns that a payer has with regard to current treatment of hepatocellular cancer? So we've touched on the fact that there are cost-effective systemic therapies, immunotherapy, targeted therapies for liver cancer, and certainly for a reasonably smaller but a specific population, liver transplant is also a realistic treatment option. But with all of that said, and really observing this from the bird's eye view of a healthcare payer, we see that there are still a lot of uncertainties in clinical practice, which frankly result in deviations from care from one patient to the next in terms of how their liver cancer is treated. And we've also talked a little bit over the course of the day around some of the reasons for that, and again, ranging from ranging from access to care, access to specialists, other access to transportation, for example. But really just to hone in on the reality that, again, liver cancer is, for the most part, usually diagnosed late. And so curative therapies, even though they exist, may not necessarily be appropriate by the time that someone has been diagnosed. And in some cases, some people are diagnosed so late that curative therapy may not be an option at all. Obviously, one of the other things that we see are variations in deciding if a patient is an appropriate candidate for systemic therapies. And another variation that we often see is that when it is identified that they are appropriate candidates, at what point during their treatment course do they receive some systemic therapy? We see sometimes that people will receive local regional treatment first. Sometimes it happens somewhere in the middle of their course of therapy. So there is that type of variation as well. And I think just to be very clear, while we're fortunate that a lot of these systemic therapies exist and have made significant headway, I guess, in the treatment of liver cancer, the reality, again, is that there are multiple factors in how they are actually used. Everything from the efficacy of a given regimen to the cost of the drugs to a patient's, personal preference or what have you. So again, from the bird's eye view of a healthcare payer, I want to talk about 3 other opportunities that are, again, relevant to current clinical practice. The first one is really not something that we've talked about at all today, and I'll just touch on it briefly. It's with respect to hospice care. The second is with respect to patient adherence with their medications. Again, we've touched on it a little bit, but I do want to hone in just a bit more around the opportunity there. And the third pertains to the opportunity with biosimilars. So firstly, with regard to hospice. So there was one study that included over 8,000 Medicare patients with liver cancer. And of those 8,000, only about 15% actually received treatment with either chemo or an immunotherapy or radiation. And 50% received no treatment at all. And the interesting thing here for this study was that over 60% actually did receive hospice care. And most interestingly to me, the people who were on hospice actually had a median survival that was slightly longer by 1 month, admittedly not long, but there was a 1 month longer survival relative to what was otherwise an 8-month survival. And more importantly, well, no, I should not say more importantly. There were a couple of other findings in addition to that longer survival. There were also fewer ED visits and hospitalizations and improved quality of life by patient report. And so I'm highlighting this today just so that we can consider the role of palliative care and hospice care in liver cancer, and particularly for its ability to potentially improve survival and quality of life as well. Okay, so the second item I wanted to highlight here is around patient adherence with oral regimens. For patients staying on track with, a patient who has multiple chronic conditions, staying on track with their medications is a challenge at the best of times. And now all of a sudden you've added a new diagnosis of liver cancer, so that's stressful in and of itself. There's a whole bunch of new providers that they have to see. There's a bunch of new medications that they have to take. It's easy to get off track with the medications. And so, there are obviously multiple barriers to a person or to a patient continuing to take their medications. Everything from patient understanding to drug cost to medication side effects to just being able to get to a pharmacy to pick up their drugs. All of these things are relevant. And so, we've got studies in this liver cancer space showing among both commercial, Medicare, and VA patients that the non-adherence rate is in the 30% range. So, obviously with a diagnosis of cancer, a 30% adherence rate does call into question whether the regimen itself is going to be efficacious. And so, we do need to be thinking about that and what we might do to address that. And then the last thing that I wanted to say just for a moment here is with respect to biosimilar drugs. So, obviously one way to think about biosimilars is that they are like the generic version of our immunotherapies and targeted therapies and so forth. and not to belabor the point, but advances in care, as spectacular as they are, don't mean anything if we can't afford them. Okay, and so the patient and the system has to be able to afford them, and so biosimilars can really significantly impact access to care, and frankly improve cost effectiveness of the overall regimen. And so we definitely want to be thinking about leveraging them where it may be appropriate. And we also the payers need to have very clear medical policies that really talk through the coverage criteria for those, and so that providers know what to expect when they submit a bill. All right, so let's talk briefly about the role of the health plan and disease management that health plans offer. For a health plan, each of our members comes to us with complex medical conditions and even more complicated lives. We recognize that each member is unique, and we have a system of care management, a team of disease managers and care coordinator nurses who are experienced in identifying and addressing each of these unique circumstances. And it's routine for us to use our claims data, our lab data, our pharmacy data, and other information, not only to identify at-risk populations, but then also to then connect with those targeted populations that we've identified, educate them on how to optimize their health. That might be everything from educating them about their disease process to educating them about their medications or how to manage or mitigate side effects, or how to access food or transportation or pay a utility payment so that they can then focus on their clinical condition. The disease management teams at health plans typically provide telephonic support, but can also provide face-to-face support in patients' homes. And really through this process of regular contact with patients and also through connecting the patients with other resources. It might be a home healthcare nurse, or it might be with tools and technology like digital apps. All of these types of supports and wraparound services are things that health plans can do to support patients. There are a couple of critical functions that managed care organizations have. Certainly one, and when it comes to providers. And one of them, I would argue, is really making sure that our members have access to the quality network providers that they may need, as well as to other community resources. And then the other thing that is really an important function for a health plan is for us to be, I alluded to just a moment ago, all of that data that we have access to, that claims data, the lab data, the pharmacy data. Well, that's also something that we want to be able to share with our network providers as well, so that they can optimize their patients' health. There's certainly an opportunity for us to provide basic provider education. Again, we talked about a moment ago how physicians don't necessarily even feel that it's their place to screen for liver cancer. So there's an opportunity for us to provide some basic education around that. But then there are other very more specific things that we can do. We can provide detailed lists of patients to our panel of primary care physicians to let them know which of their patients actually are at risk for liver cancer based on diagnoses or lab tests or other information that we may have access to that they may not be seeing. And so in addition to offering this basic education, more specific patient information, there really is a very specific place for us to engage our physicians through value-based contracting. And again, I think this has been touched on a couple of times over the course of the day, but it's really important for us to recognize that, for example, we can reward oncologists based on quality measures that are designed to improve outcomes and also to reduce costs in the setting of liver cancer. Some of the measures that we might be tracking over time might include things like surveillance rates for people at risk of liver cancer. It might include things like clinical pathway compliance. It might include things like reduced ED visits and hospitalizations, med adherence, patient status, patient satisfaction. These are all the types of things that they might be looking at. Other options for value-based care delivery could include, and again, these are things that we've talked about over the course of the day. It might include things like encouraging the use of a center of excellence for liver cancer, or using a specialized provider network, or encouraging the use of a multidisciplinary tumor board to collectively agree on a treatment approach. All of these things are potential opportunities for us to incentivize healthcare providers in this space. All right, so we've walked together through a payer's perspective on those considerations that make us pay attention to liver cancer. We've talked about what we should be doing to prevent and screen for liver cancer, our thoughts about opportunities in current clinical practice, and also noted some of the opportunities for health plans vis-a-vis disease management and our providers, and especially value-based contracting. So let's turn our attention now briefly to expectations and guidance that our legislators and regulators might offer or even require in the setting of liver cancer. So one of the first things that I can tell you, at least just based on Texas Medicaid, is that they could choose to designate people with liver disease or people with hepatitis or people with liver cancer as a member with special healthcare needs. And the reason that's important is that then triggers the payer to pay extra special attention to such designated members. And really it triggers an automatic increase in scrutiny and disease management and some other activities. And speaking of disease management, the government can require tailored disease management for people with these diagnoses. And that then triggers other linkages to appropriate medical care and things of that sort. Now, the state Medicaid regulator might require health plans to coordinate with other state agencies like the State Department of Health Services here in Texas. So there's that sort of linkage to public health that we could also bring to play. The state Medicaid regulator could require us, they could develop quality-based outcomes measures and then track those for each of the individual managed care organizations and then report those publicly. And I can promise you when that starts happening, the entire system begins to start paying attention a little bit more. On a related note, the state Medicaid regulator could take advantage of an existing pay-for-quality infrastructure and align it. So not to go too far into the weeds, but the state Medicaid regulator pays managed care organizations for how we perform on a variety of healthcare quality measures in different clinical areas, and it's a substantial amount of money. It can be up to 3 to 5% of the total amount of money that they pay us annually to manage the members that we do that's essentially at risk based on our quality performance. And so, again, theoretically, potentially hepatitis C or hepatocellular cancer could become one of the conditions that is measured and that becomes part of that program. And then finally, and one of the things that we've talked about or touched on today is the fact that the government can do something to address the cost of treatment. Developing innovative payment arrangements with the pharmaceutical manufacturers, but also they could step in and address how prior authorization requirements could be streamlined and so forth. So speaking of that, I know Dr. Ward talked a little bit about what Texas Medicaid's requirements are today. I am sort of excited, not 100% excited, but sort of excited to tell you about some upcoming changes to the state Medicaid's requirements around hepatitis C viral treatment that are slated to go into effect on January 1st. I'll tell you, they were originally slated to go into effect on September 1st of this year. That got delayed because the state did not conclude its negotiation with whichever pharmaceutical company they're negotiating with. But the intent is that they will have one designated direct-acting antiviral that will be on the preferred list. And if the provider chooses to use that particular drug, then no prior authorization will be required. So regardless of the Medivir score, regardless of the provider, so it doesn't have to be a hepatologist, it can be a primary care doctor, it can be any Medicaid provider can prescribe that. There won't be any drug screening required or any expectation around sobriety. There won't be any additional refill authorization reviews or anything required. Now, all of that is in place or will be in place on January 1st, assuming you're picking that one drug that is that they have contracted for. So for any of the other direct-acting drugs, presumably some sort of prior authorization process will still apply. We don't know exactly what the guidelines for that will be, but that will be. Yeah, sure. Okay, so the last couple of things here that we want to talk about are around this framework for how we can move forward for policy. And this is really drawn from a federal work group that was convened by the Federal Department of Health and Human Services. They convened an affinity group back in the several years back of multiple Medicaid state agencies, and specifically to focus on what they could do around hepatitis C. In addition to HHS's lead role, there were other agencies involved. The CDC, CMS, HRSA, SAMHSA were also involved. And so I just want to talk really quickly about what some of the activities that the state Medicaid agencies were engaged in and how we can actually bring those to bear in our conversation around both hepatitis C, which is what they focused on, but how we can expand that to think about liver cancer. So there were really 5 sets of activities that all of their things could be combined into. The first was really related to using data to inform policy. So states developed data use agreements between the state Medicaid agency, public health agencies, and corrections departments to exchange information about their individual patients. So that was something new, but that was something that they were able to make progress on. They aimed to identify screening and treatment patterns for certain populations, so for populations with HIV, for women, for incarcerated people. They analyzed data to identify high burden areas, and then they tried to figure out, well, here's a high burden area, there are no providers here, let's try to increase provider capacity there. A second activity really had to do with enhancing provider capacity for testing and treatment. Again, they developed educational content. They also used Project Echo and other means of teaching PCPs on what they could do. A third focus really was around people who were incarcerated, as well as those who inject drugs. There were new systems of care developed so that people who were coming out of incarceration could quickly become Medicaid eligible and have access to care that was determined even in advance of their starting out there. And so 2 additional sets of activities really focused specifically around the direct-acting antivirals. One was making them more affordable, and we've heard a little bit about the subscription model. There are other Medicaid payment opportunities as well to consider. And then, like we talked about Texas and some of the dispensations that the state of Texas is making, there were other very specific structural barriers that were also removed. And then lastly, they came up with a whole bunch of resources that we can still tap into, in the spirit of not reinventing the wheel. There are a variety of provider trainings, payer trainings, resources on Medicaid drug pricing, and specifically also some specific hepatitis C related measures that could then be monitored and tracked over a period of time, and again could be used to incentivize providers and payers alike. So really to recap, we first talked about why payers are interested in liver cancer. We have highlighted some potential directions that the state government can take, and I quickly talked about a very specific framework, a national framework that exists, this affinity group that whose resources we might want to certainly take a look at and potentially even emulate. So with that, I will turn it back over to Dr. El-Serag.
Thank you. wrap up, and you'll be part of the multi-stake, so hang on. So we're going to have a wrap up by Dr. Kanwal, and following that, we're going to have the multi-stake group. There are surveys distributed around the room. Please fill them, and we're almost there.
Thank you so much. All right, it's been a great morning, early afternoon. It's great to see everyone here. I'm Fasiha Kanwal. My job is an easy one. I have to just put it all together. So nothing that I will say that you haven't heard already. And you'll see your slides getting repeated in my slide set as well. So I took the liberty of just borrowing things without your permission. And also, I will serve as a bridge. I think that's probably the most important part of my job, is to serve as a bridge between what you've heard already to where we really want to go next, which is this roadmap to our final objective to reduce mortality related to HCC in Texas. So as I was thinking about what really could be the main thing that I can leave you with is this number 3. So if we can think about just 3 things, 3 targets for action. We heard a lot. There are lots of gaps, lots of barriers. I wish we could do it all. I wish there would be this very complicated, complex roadmap that we can put together, but really I think it will be difficult, if not impossible. So I am thinking of just 3 action items, 3 calls to action, 3 low-hanging fruits, whatever you want to call it. Just leave with the number 3. And as I was thinking about number 3 and all the symbolism that happened earlier today, I don't know why did I gravitate to number 3. I have 3 kids, and that's the most that I can handle. Maybe that's the reason, but there's more behind it. So Greek philosophy, they rely on number 3 as a balance. This is a number that reflects wisdom, the past, present, and future. So I think we'll learn what we learned from the past, know where we are, and really apply it to future. Though we can go with number 4. So poor kids. Anyways, so let's think of number 3 as where we want to end today. And these 3 are going to be stops, intermediate destinations, as we look towards the actual destination, which is trying to reduce mortality from HCC in Texas. And I don't have a perfect roadmap to share with you, but I think that's what we will do together. Think of where we are right now. How do we get to these intermediate destinations? That will be our task during the discussion section. And again, nothing that I will say that you haven't heard today already. So I'm just going to recap, leave you with what I think those intermediate stops could be, but really it's open for discussion and conversation, and hopefully we'll come up with something together. I don't have to say it again. Aaron pointed out many people also underscored Texans, they have a high burden of HCC, probably the highest. Also, people who develop HCC in Texas, they live shorter than people with HCC elsewhere. Dr. Rich mentioned that. We also found that there are opportunities, despite the burden that we have, despite the challenges that we have, as Dr. Turner pointed out. I think there are still some opportunities that are important to talk about. And I'm going to mention 3 opportunities. One is that these risk factors, these high priority areas for risk reduction, Aaron Thrift talked about it, and at least some of them are under our control to some degree. And that I think of that as an opportunity, as pointed out by Dr. Ward. So viral hepatitis, HCV, HPV, overweight, obesity, yes, very difficult to change, but at least we can increase recognition and awareness around that, and alcohol consumption. So these are important targets for risk reduction that I have us come back to. We also talked about this lesion, precursor lesion of cirrhosis. These risk factors that we just highlighted, they all work by causing liver injury, liver inflammation, which lead to cirrhosis or scar tissue in the liver. And that is the underlying precursor lesion for most people who develop HCC. Most everyone with HCC has cirrhosis, and it is potentially identifiable. We heard about it. I think time to use this information and really help us move forward. And the third point that I think I see as an opportunity, we heard it from multiple speakers about the fact that even for people who progress to HCC, it's not end of the road. If we detect it early, there are treatments that are helpful. Early HCC is treatable. Even people with more advanced HCC, there are newer treatment options that are available, but the main thing there is early detection. So with that, this is the framework, the cancer care continuum that Dr. Rich shared with us. The 3 points that I mentioned to you, they align nicely with the first 3 steps in the cancer care continuum. And yes, we have a lot to do, a lot of gaps, a lot of problems that we have to solve. But I would recommend, or I would suggest that we think about these first 3, step A, B, C, as we start on this journey towards reducing cancer mortality in Texas. And with that, again, wrapping up, bringing us to where we heard before, there are 3 risk factors: viral hepatitis, NAFLD, NASH, alcohol-related liver disease, and there's one key high-risk group, people with advanced fibrosis and cirrhosis, that we really could focus on, and these could be the low-hanging fruits for this initiative. I'm going to just quickly talk about each of them. Won't really take a lot of time because we heard about them quite a bit. This is from Dr. Ward. Texas is among the top quarter in terms of prevalence of HCV. We are very big in size, so this percentage can translate into a large number of people. We also heard about that with hepatitis C virus infection that's still untreated. Also, we heard that the goal globally set forward by WHO is to eliminate hepatitis C virus infection-related burden by 2030. This is 2022. You probably all remember where you were 8 years ago. Time flies fast. We have 8 years left running against time. And we really do not have much happening here in Texas in terms of really trying to address this issue. And when we think of elimination, and that's Dr. Ward's area, the goal is global elimination. I completely agree with that. We all agree with that. But really, at least standing here, it's out of my influence. Under your influence, but out of my influence. So maybe we focus on things that we can influence, which is the lower levels, maybe regional, state-level elimination program. I think we're in a place where we could influence that to some degree. And if you think of, again, things at micro-elimination level, these are initiatives, interventions that targeted, focused populations. And I think we have a good example for micro-elimination from Dr. Turner's program, and we heard about that, about its success, but also about the challenges that she highlighted really nicely in her presentation, which makes me think that we really need to go to the next level. There are many examples in efficacy, effectiveness, and dissemination programs that we've had, demonstration programs. I think we need to think bigger. We were already talking about it earlier, and really need to move towards statewide programs. And we have a great example. We heard about it from Dr. Ward, or I should say a good example to follow. I'm sure there are many other ways that it could be improved upon. And as we stand right now, we don't really have that in the state of Texas. So for hepatitis C, my first recommendation for call to action is let's think big, at least at the state level. We've done many efficacy studies, we've done many effectiveness studies, there are many demonstration projects. Time for a policy change, time to think big. And I think the first call of action could be this. Now the goal for us as this group is to think about what do we do from here till we really make that happen. So that's for Hep C. For NAFLD, again, briefly talk about, highlight the burden that was highlighted by Dr. Aaron Thrift sitting right there, global problem, but really big footprint locally here. It disproportionately affects people in Texas, associated with HCC, but the problems are different. And I think our focus and our vision should also align with that. It's a big problem. Many people have it. Finding that small subset that is at high risk is challenging. And I think that's where we need to focus on. That's number one. Second is not many people know that this is a problem. Not many people know where to start screening these 25% of people who are at risk for NAFLD. But I think there is a way forward. This is probably the only new thing that I'll share with you today that you haven't seen already. This is an AGA NASH clinical care pathway that was published last year. The one good thing about this pathway, it identifies 3 highest risk groups in our communities that could be targeted for initial screening for NAFLD or NASH-related fibrosis. So I think that's probably the first step, necessary step as we implement similar programs, pathways in our populations. Under-recognition was highlighted before. Not many people are aware that this is even a risk factor for liver cancer, and I think that's where we need to start. So for NAFLD, we have a lot of work to do. We have some efficacy studies coming up, but lots of information, lots of data that we still need to collect. But we shouldn't really sit and wait for all of those data to emerge. I think this is the time. It's all bundling it all together because they all jointly affect increased risk. I think the main things we still need to push for, but maybe start at the first step, which is awareness. Make sure people understand it's a common problem and understand that it contributes to HCC. And then at the same time, ask for other real-world evidence. And I think we do need some demonstration studies for NASH and EPFOD also. The last thing is this notion that there is an underlying lesion that puts people at high risk for HCC, which is identifiable, and which is a reason why we also miss people with HCC. Failure to recognize patients with cirrhosis or advanced fibrosis contributes to underdetection, underdiagnosis, and late diagnosis of HCC. And that is very nicely presented by Dr. Fortune, is another opportunity using data, electronic health records that we have access to in most circumstances, to really try to find these people earlier, link them to care, and see if there is something to be done about their HCC surveillance. So I'll just quickly go through that, but that I think is another area, maybe call to action for us to think about. I'm going to just talk briefly about HCC screening. Amit is not here, otherwise he would probably stop me here. But I do think there is more information that's needed for HCC screening before we really bring it up to where it needs to be. So we continue working actively on generating this evidence. We probably should move towards more demonstration projects, but is it really going to be one of those top 3 low-hanging fruits? I'm not so sure. I'll leave it with you. And of course, we will discuss that in the next hour and a half. So this is the 3 potential targets, 3 intermediate destinations, stops that we can think of in this roadmap as we move towards the final destination, hopefully. Again, challenges are many. We recognize them, but at the same time, as you heard from other speakers, it's time to take action. We cannot keep waiting any longer. So I'll leave you with this, and really looking forward to an engaging conversation, discussion for the next 90 minutes or so we can come up with next steps together. Thank you.